Good morning. Today we will have a case presentation on liver mass. The case will be presented by Dr. Ishita Laha, who is a third-year junior resident at RKM Share Pradishthan and Bihar Institute of Medical Sciences. Professor Saurabh Ghosh, Professor and Head of Oncosurgery at Calcutta Medical College, who will take us through the scenario. Ishita, you can start share your screen and present, and wait at the end of your history presentation. We will discuss and then proceed to the examination. Okay.
Good morning, sir. Good morning, everyone else. I present my case as a, I'm sorry, sir, it's Mr. X, a 67-year-old gentleman, resident of Sundarban, a farmer by profession, presented with the complaint of loss of appetite and loss of weight for 5 months and upper abdominal fullness for 2 months. On history of present illness, the patient was apparently well 5 months back. Then he gradually developed loss of weight and appetite. He noticed upper abdominal fullness for 2 months and not associated with pain, no aggravating or relieving factor. History of cough for last 1 week. No history of fever, trauma, or abdominal distension. No history of passage of clay-colored stool. No history of yellowish discoloration of eyes and urine, and no history of chest pain and hemoptysis. No history of previous jaundice, no history of blood transfusion, and no history of hematemesis. In past history, no comorbidities like diabetes mellitus or hypertension, no history of any exposure to tuberculosis or any taking any prolonged medication for any chronic illnesses, no history of similar illness in the past, no past surgical history, and no history of any allergy to any known food or drug. He takes a mixed Indian diet. Sleep is normal. Bowel bladder habits are normal. He's a chronic alcoholic and a chronic smoker. And socioeconomic status is lower middle class by modified Kupuswamy scale. No history of similar illness in the family. I summarize my history as a 67-year-old gentleman presented with a loss of weight and appetite for 5 months and upper abdominal fullness for last 2 months and not associated with any pain or any aggravating or relieving factor. Associated with cough for 1 week. He is a chronic smoker and chronic alcoholic and no history of previous jaundice, blood transfusion or variceal bleeding.
At this point of the history, is there anything that you are specifically thinking of? What are the possibilities that you're thinking of?
Sir,
just upper abdominal fullness and anorexia in an elderly male.
Yes, sir. Sir, given that he's he's having a loss of weight and appetite, so it actually points towards any sort of malignancy. And sir, upper abdominal fullness can give rise to liver malignancy, gallbladder malignancy.
No, Ishita, don't jump to liver. Just given your scenario liver mass, I did not find any symptom in this patient which will suggest, at least on the history, that patient has some liver pathology. He has no jaundice, he is not a hepatitis carrier or whatever. So think of more commoner causes. This is a classic presentation of another entity in the upper abdominal pathology. That is also malignancy. What is that? Not liver.
So pancreatic, sir. Pancreatic CA.
Even stomach CA.
Yes.
Gastric
So I would make stomach CA as the number one. This is the classic presentation of patient having a gastric malignancy. Cannot just anorexia weight loss. And this addition of fullness in the abdomen is more in favor of a likely to be gastric pathology. It is true that patient having liver malignancy may not have any specific symptom pertaining to the liver disease.
Pertaining to liver, yes.
Agreed. But that you always keep quite low.
Later in your differential diagnosis.
Yeah. Not from the history, sir, directly.
Yes, in history, there is no suggestion. You see, what is the point? Tell me. What point in the history suggests that this patient may have a liver malignancy?
A chronic alcoholic.
Chronic alcoholic. Yes. No,
so, but why malignancy? Chronic alcoholic, there may be just chronic hepatitis. Alcoholic hepatitis, even that will cause some amount of anorexia.
Yeah.
So don't go to malignancy first. Liver malignancies by and large are very rare. Right. Carry on. Please carry on.
Okay. Thank you, sir. On physical examination, general survey, my patient is conscious, alert, and cooperative and oriented to time, place, and person with a Karnofsky score of 80. BMI is 19. He is thin built, decubitus of choice, hydration adequate, and pallor is present, and no history of no examination suggestive of jaundice, clubbing, cyanosis, pedal edema, engorged neck veins, or generalized lymphadenopathy, and no left supraclavicular lymph node enlargement. No stigmata of liver disease present. On vital signs are as follows: pulse of 78 beats per minute in the right radial artery, regular rhythm, normal volume, with a BP of 110/70 millimeters of mercury in the right arm supine position, respiratory rate of 15 per minute, and febrile. On abdominal
Can you
examination,
tell me what are the stigmata of chronic liver disease?
yes, sure, sir. Sir, it includes palmar edema, thenar, hypothenar eminence, and there is a tremors, and gynecomastia, testicular atrophy, and spider nevi, and Dupuytren's contracture.
Okay.
And sir, proceeding to my abdominal examination, I have explained the patient as what am I supposed to do, and with full consent, in a well-lit room, I go ahead with my examination. Inspection of the abdomen is scaphoid in shape, and umbilicus is central and inverted. Fullness noted over the right hypochondrium and epigastrium. All quadrants are moving equally with respiration. There is no erythema, sinuses, scars, or dilated veins present. No visible pulsation or visible peristalsis. Flanks are not full, and hernial orifices and external genitalia normal. Carnet test shows no prominence of the fullness. On palpation, no local rise of temperature or tenderness, no guarding or rigidity present, no nodules in and around the umbilicus, a palpable mass of size 6 into 8 centimeter below the right costal margin felt, which is irregular surface, ill-defined margin, firm in consistency, and moves with respiration. Fingers cannot be insinuated between the mass and the costal margins, and it is fixed to the underlying liver and free from skin. No other mass palpable, no other organomegaly. Palpation of renal angles are normal, and hernial orifices are normal. On percussion, dullness is continuous with the liver dullness that is up to the 8th rib in the mid-axillary line, and no free fluid present. On auscultation, normal bowel sounds heard and no bruit heard over the swelling. On digital rectal examination, no fissure or hemorrhoids present. Tone is not raised, and fecal staining of gloved finger showed yellow-colored stool. On my systemic examination was essentially normal, and there was no evidence of encephalopathy.
You mentioned about the liver dullness, upper border of liver dullness. Why in the mid-axillary line? Any particular reason? Why not the mid-clavicular line? The patient is lying supine.
So, because mid-axillary line, it is not it is unlikely that we get the dullness till the 8th rib. Sir.
Is it normal that we would get it up to the 8th rib in the mid-clavicular line? What is the normal upper border of liver dullness present? In the when you normally describe upper border of liver dullness, where do you do it? In the axillary, mid-axillary, or the mid-clavicular line?
The mid-clavicular line.
Why did you suddenly say mid-axillary line? For mid-axillary, you would have to turn the patient to the left, then ask him to raise his arm, then go. And up to the 8th rib, I would think even in the mid-axillary line, you might get liver dullness. I have never done it in the mid-axillary line, but if the mass is pushing the liver up, if it's a big mass and the liver is going up and it is pushing the diaphragm up, then the liver dullness upper border will go higher, not lower. So if it's normally in the 5th space, it might go to the 4th space. But if it is in the 8th space, I suppose normally the liver is present. Why would it not be dull? That is not an abnormal finding. That is my opinion. Maybe Professor Shah can comment or clarify.
In medial dose is not in the 8th space. You are talking of spleen. Spleen is 8, 9, 10 on the left side.
Yeah, for spleen, you might use the mid-axillary line. But for liver, you normally use the mid-clavicular line anteriorly. Why bother to make the patient turn to the left side? Anyway, carry on.
Sorry, sir. I shall take care of this. Sir, I summarize my case as follows. A 67-year-old gentleman presented with a loss of weight and appetite for 5 months and upper abdominal fullness for last 2 months, not associated with any kind of pain, and associated with cough for 1 week. He is a chronic smoker and chronic alcoholic and no history of previous jaundice, blood transfusion, or variceal bleeding. On examination, general examination is essentially normal with a BMI of 19. On inspection, a fullness present over the right hypochondrium and epigastrium. On palpation, a palpable mass of the size 6 into 8 centimeter below the right costal margin, irregular surface, ill-defined margins, firm in consistency and in moves with respiration. Fingers cannot be insinuated between the mass and the costal margins. It is fixed to the underlying liver and free from skin. And on percussion, liver dullness is increased over the mid clavicular line, and on digital rectal examination is within normal limit. I provisionally diagnose my case as a 67-year-old gentleman with a liver space occupying lesion, probably malignant in nature.
Okay, so this is your provisional diagnosis. What is the point? Would you like to offer a list of differential diagnoses along with it before I go into the points in favor?
Yes, my differential diagnosis will be, sir, gallbladder CA and sir, gastric CA. Pardon,
Gastric CA presenting as a lump in the right hypochondrium. What would that lump be? The stomach? The mass, the gastric mass going into the right hypochondrium?
No, sir. Metastasis from gastric CA, sir. I mean,
okay, so the secondary is in the liver, whether gastric or colonic or kidney or whatever, or pancreas, metastasis, liver metastasis. Okay, you said it moves with respiration. What are the masses which move with respiration? What are the
sir, masses as in liver mass, gallbladder mass, and kidney mass, and sir, also sir, gastric mass.
How about spleen?
Yes, sir, splenic mass as well.
If it's the tail of the pancreas mass?
Sir, it is movable. It does move, but we cannot examine it. Means we will not we will fail to appreciate it during our clinical.
We will. You can never palpate a large mass arising from the tail of the pancreas, a cystic neoplasm of the tail of the pancreas.
I'm sorry, sir. I have not come across it.
You may be able to. Any mass may be palpable if it is large enough. And generally, body tail masses, they become larger in size because they don't present with early features like obstructive jaundice. So sometimes you do get large masses in the body and tail of the pancreas. And if it is what is the reason behind the mass moving with respiration? It is in contact with the diaphragm. The diaphragm moves down, it pushes the mass down. So any upper abdominal mass, if it is large enough and if it is in contact with the diaphragm, it might move with respiration.
Okay, sir.
Okay. So
actually, some part of clinical part. You see, go back to your examination, palpation part.
Yes, sir.
I'm not happy. A PG should have a better description. You see, you are describing a mass, and you are not altering that this is liver. You are trying to say it's fixed to the liver. Try to understand that patient having a mass in the liver, there may be some amount of hepatic enlargement also. It is very unlikely that only the nodule is palpable. Okay, so even the nodule is palpable, is the liver, you can, as in a postgrad examination, you can straight away describe that liver is palpable because all the features you're describing is classic of liver. And you describe this nodule is arising, it's not fixed to the liver. Try to understand. Okay. This is not a nodule which is fixed to the liver. The description says that this is a nodule arising the liver. So you can describe that liver is palpable in the right subcostal area, this centimeter below the costal margin, and there is a nodule which is having a smooth surface, or you can say it's a nodular surface, and you describe the extent and straight away infer that is the liver mass, not keeping it to be at the diagnosis. Okay, so it's a liver mass.
Okay, sir.
And come to the inspection part, that general survey. Actually, Chintamani is very particular about this term. What he said is, you said abdomen is moving. Inspection of the abdomen. You are saying abdomen is normally moving with respiration, all quadrants.
Yes, sir.
It is said that if you see a patient, when the patient takes a breathing, the upper abdomen moves more than the lower abdomen, lower quadrants. So the better term to use is
So
abdomen is
abdominal
moving.
thorax.
Yes, no, the abdomen is moving proportionately with respiration. That means you expect the upper abdomen will move more than the lower quadrants. So all the quadrant doesn't move equally with respiration.
Okay.
So there is some examiners passion, particularly patient. Okay. So otherwise you have covered it well. Okay. So it's a malignant liver mass. Okay. Dr. Shora, please.
Dr. Ishita, I say this is I would also like to keep an amoebic liver abscess in the differential diagnosis. What would be your point against that diagnosis?
He did not present with any fever.
In amoebic liver abscess, fever is not very common. Pyogenic liver abscess, fever is very common, you know.
Sir, amoebic liver abscess will present with toxic species, but
no, before that, what about pain? This patient is
pain,
almost
pain. Yes, pain will be there.
Abdominal liver abscess can cause local expansion, then inflammation. There will be pain. Fever is not very predominant in liver abscess, but pain is there, is definitely. And what about your examination finding? How it differs?
Sir, maybe we may not find any clinical examination findings, sir.
You see, Dr. Ghosh has asked you, this patient with this mass, what is the features that suggest, yes, it is malignancy and not amoebic liver abscess? Sometimes amoebic liver abscess, you can palpate a enlarged liver. What is the characteristics in that? What do you feel about this consistency of this mass?
Sir, it will be cystic, sir. It will be a cystic field.
You cannot always appreciate a cystic mass. You see, if it is a abscess in the depth of the liver, a cystic appearance is not always discernible. But
so it will be tender on palpation.
Yes, it's tender and if a malignancy mass will be very firm, it may not be firm. Okay.
So malignancy will be more firm to hard.
Yeah.
Yes, sir.
And what you can find? Else you can find edema in the intercostal space. Apart from the tenderness, you may have edema in the intercostal space that is more in favor of a inflammatory mass in the liver.
Okay, sir. Edema in the intercostal space can be appreciated by pain on percussion.
No. Pain on percussion and
edema will be edema. It's a palpatory finding.
You can indent this, and you can have intercostal tenderness also in amoebic liver abscess.
Okay.
So what are the
one
points
is
against your diagnosis,
primary malignancy.
Pardon, sir?
So what are the points against your provisional diagnosis? Do you find anything that makes you worried that it may not be the right year?
So, one thing
in your history or your examination.
Yes, so there is no history of any previous jaundice and no history of blood transfusion. And sir, as sir, you previously said that chronic alcoholism can lead to several other differentials. So, and from the presentation, otherwise, sir, from the clinical examination, we can infer it to be something originating from the liver associated with loss of weight and appetite points towards malignancy.
What are the more common?
Why not a secondary from some other
secondary? What are more common liver tumors? Primary or secondary?
Secondary, sir.
Secondary.
So why not a secondary?
Sir, because from the clinical examination, we could not delineate any source of the primary.
That can happen. What are the more important feature on examination which will suggest, yes, this likely to be a secondary lesion?
Sir, it will be nodular and multiple, sir.
Yes. So it can be even in
solitary metastasis, no doubt can be palpable, but more likely, sir, we expect it to be multiple.
So if it is multiple, then it is more in favor of a metastatic disease.
Yes, sir.
Even a HCC may be multifocal also.
Yes, sir. Yes, sir. Multifocal HCC is there.
So, Dr. Ishita, so let us accept your provisional diagnosis that it is probably a liver malignancy and it is more likely to be primary rather than of a secondary origin because there is no obvious primary elsewhere. So clinically, we cannot say it is secondary. Also, as you said, secondaries are generally large secondaries. You would expect them to become multiple by the time. But this is like more like a solitary lesion. So, how do you want your diagnosis? Do you want any tissue diagnosis?
No, sir. We will first go for ultrasound. Means I will like to confirm my diagnosis and thereby go on to stage and then treat my disease. So
Good.
if
Confirm the diagnosis,
So by
investigate to
confirmation, you
stage the
don't want a
disease,
tissue diagnosis.
and plan for management.
Sir, for if I see after means for confirming the diagnosis when I do the ultrasound or CT scan, if I see the lesion is small and can be resectable, so we may not go for a tissue diagnosis
পরে
in the
ক্লাস
beginning.
করছি পরে কথা ক্লাস করছি
Okay. Okay. Why not? What harm the tissue diagnosis?
The
do?
tissue diagnosis will.
I generally go ask for a biopsy for most cancers that I see. Why don't you want to get a tissue diagnosis?
Sir, tissue diagnosis means if it is resectable, sir, we may not have to give any chemotherapy against it or so. So we may not need a tissue diagnosis. And needle
So
track,
you say
needle track
that
recurrence will be there. Seedling will be there. And hemorrhage, sir. And if it is hemangioma,
say that every resectable liver lesion does not need to be resected. It may be a benign liver lesion also, which can be observed.
yes, sir.
It may be a focal
Yes,
nodular
yes,
hyperplasia.
yes, sir.
So,
Sir, and in sir, and if our lesion
the
is
main two problems are. Yes, go on.
sir,
Go
if
on.
our lesion is hemangioma, it can cause
Please.
to rupture. Also.
Bleeding.
hemangioma has
So the
different
two main
imaging picture.
complications
Don't
of
confuse.
Yes.
no, sir, it's okay. I have not gone into the imaging. I am just saying in general. So in a liver mass, the two issues with tissue diagnosis, one is the chance of bleeding. Even if it's not hemangioma, if it's a adenoma, liver adenoma, sometimes in a small lesion, it may be difficult to differentiate between an adenoma and a carcinoma for a very small lesion. But we still don't jump to tissue diagnosis first because of the risk of bleeding, one, and if in case it is a malignancy, then the small chance of needle track seeding. And so you are absolutely right that we will not go for tissue diagnosis first, but you have to tell me those things. So don't directly say because it is resectable, I can go ahead with resection. So if you are not going to do tissue diagnosis, how are you going to establish the diagnosis?
So I will do MDCT, means I will first do ultrasound and then after confirming my lesion, means after.
So what are the main things that you're looking for in ultrasound?
So,
what does ultrasound tell you?
So ultrasound will tell me the anatomy of the mass, the origin of the mass.
Okay, origin of the mass. So it's a liver mass. Ultrasound will confirm that it is a liver mass, not a gallbladder mass or something else.
Yes,
then,
yes, sir. And then whether it is a cystic mass or a solid mass.
Very good. Ultrasound is very good for defining cysts. So whether it is cystic or not, we know that in the liver mass, what are the common cystic masses which are coming, the differential diagnosis of liver mass?
Sir,
2 or 3, quickly.
Sir, hydatid cyst, sir.
Yep.
And simple cyst and polycystic disease of liver.
Polycystic disease. Then we just now discussed amoebic liver abscess, pyogenic liver abscess.
Yes, sir. Amoebic and pyogenic liver.
So these are the things that you have to consider in a liver mass. So the ultrasound will tell you whether it is any of these things, right? It is cystic or not cystic. Then what else?
Sir, it will show us, it will delineate if there is any lymph nodes, and it will delineate.
Ultrasound lymph nodes. Ultrasound is not a good test for lymph node. It will not tell you
anything else in the liver. Anything else in the liver?
Sir, yes, sir. Sir, if it is metastatic deposits or not, and if so, then the intrahepatic biliary radicals, then the gallbladder
metastatic, and how will ultrasound whether it is metastatic or not, or primary? It can say whether it is solitary or multiple. If there are other lesions, which are not clinically evident, but on ultrasound you find that on the left lobe also there are 2 or 3 smaller lesions.
And the segments involved. And the segments involved.
Again, segments you don't really judge by ultrasound. It give you, obviously it will give you some idea, but you don't really decide on the segments by ultrasound. So for ultrasound, I would just look for these 3 or 4 things. Sir is specifically asking for something else. What, anything else in the liver? Other than the tumor, think beyond the tumor.
Sir,
The
any
tumor can
were
be
examining
age
anything for-
separated.
sir, portal vein, sir.
Exactly. So the
portal
signs of chronic liver
Talk of
disease.
cirrhosis also. Cirrhosis.
cirrhosis.
Cirrhosis,
Yes,
you have to say.
cirrhosis.
So
Cirrhosis.
that is all I'm looking for from ultrasound. First of all, confirmation that it is a liver mass. Second, whether it is cystic or not cystic. Third, whether there are multiple lesions, which I have not been able to understand clinically. And fourth is associated liver disease signs like ascites and all. Ultrasound will pick up portal vein diameter more than normal. All these things. That's all. Whether it is grossly nodular, which I may not be able to palpate in a very obese man, although your patient is a thin-built guy. In an obese man, palpation of nodularity of liver requires great skill and experience. I may not be able to do, you may not be able to do. Professor Shah may do. He has palpated so many livers. So ultrasound will help people like us who are not so experienced in clinical. But I don't look to define the anatomy or the segments by ultrasound. For that, I will go for
Sir, MDCT.
CT scan, contrast enhanced CT scan. If specifically you want to use another term rather than MD, MD is multi-detector.
Sir,
What
yes, sir.
kind?
Sir, then triple phase CT scan, sir.
Correct. So say triphasic. You can use
Triphasic.
an MD CT scan to do a non-contrast CT also. But
Yes.
for a suspected liver mass, you will not do a non-contrast CT. You will ask for a triple phase CECT of the whole abdomen.
And some people are using the term quadruple phase CT for liver. 4 phases for liver.
So
Okay, keep on triphasic, no problem.
So now, what are the features? So suppose it is an HCC. If it is a primary liver malignancy, what is it most likely to be?
Sir, it will be, sir, it will take up the in arterial phase. It will be
What is
early
the commonest primary liver malignancy
uptake.
in an adult?
Sir, primary liver malignancy is metastasis.
No, that is
Primary
commonest.
liver.
Primary liver.
Sir, then it is fibrolamellar variant, sir.
Come on, what is the
Is hepatocellular
commonest?
carcinoma.
Simple
First, call the
question.
broad variant.
Okay,
Broad type is
hepatocellular carcinoma.
HCC. What are the other primary malignancies of the liver?
Sir, this is means the variants are you are
no,
asking?
not
Those
variant.
are variants
Another
of
entity.
HCC. What are the
Okay,
other
fine.
primary liver malignancies?
Sir, adenosquamous. Okay.
No.
Cholangio, sir.
Yes. Intrahepatic.
Intrahepatic cholangiocarcinoma. Then
Carcinoma, and then sir, cholangiosarcoma is also there.
cholangiosarcoma কোত্থেকে এলো?
Sir,
In children?
in children, sir, HCC of children is there.
That is not the commonest. Which is the commonest primary malignancy of the liver in children?
Hepato.
Sir, HCC of childhood is there something.
Hepatoblastoma.
Hepatoblastoma. Okay.
So these are also possibilities. This is not the so first of all, if you're thinking of a primary liver malignancy, since you said secondaries are unlikely, there is no feature of another primary elsewhere, and on ultrasound also it's a solitary mass. So I am thinking of HCC. So now what are the features, radiological features of HCC on a CT scan?
Sir, on arterial phase, sir, there will be early uptake and sir, there will be delayed washout.
HCC delayed washout? No, Dr. Ishita. HCC will be early washout.
Early washout.
Yes.
What happens in portal venous phase? What happens in portal venous phase? If you take a picture in portal venous phase, what do you see?
Sir, we will see it is we'll see it hypodense.
Less enhancement.
Less enhancement.
Hypodense compared to the remaining liver or the normal liver parenchyma, surrounding liver parenchyma.
Yes, sir.
Right. Achha, you kept mentioning the fibrolamellar variant. How is the fibrolamellar variant of HCC different from the conventional HCC in clinical findings and imaging findings? Please start with clinical. What would make you think that this particular HCC may be a fibrolamellar HCC clinically?
Sir, if there is a history of OCP intake, sir, if in a female.
So first start with a female. A male of 65, you will not think of fibrolamellar first.
Yes, sir.
So fibrolamellar variant is much more common in females as compared to other HCCs.
Yes, sir.
Okay, then younger age.
Younger age and pregnancy and OCP intake aggravates.
Okay, weak association is there with correct. Then
And sorry, on imaging findings, sir, there will be central necrosis, sir.
Central necrosis? Or is it another term? Central. There is something central.
Fibrosis. Right.
Fibrosis? Scar.
Central scar will
Central
be
scar.
we appreciate the central.
Anything
scar
else on investigation? Anything else on investigation?
Sir, you mean the sulfur?
There are other investigations also.
Sulfur colloid scan.
There are other investigations other than imaging.
Sir, MRI also we can do. Sir, we can do the
Other
MRI.
than imaging. In the world, there are many other investigations.
Yes.
Think of other investigations.
So
do you do any blood tests?
Yes, sir. Alpha fetoprotein we will do, sir. Blood test. Alpha fetoprotein.
So what is the difference of getting alpha fetoprotein levels for?
Is, normal, sir. In
more often to be normal in fibril
yes.
So don't just focus on one thing. You have to. I am asking you any test. So these are how the fibrolamellar variant is different from the conventional HCC. So on clinical examination, it is more common in females. It is more common in younger people. It is a more insidious onset. On imaging, it will have a central scar and which is hypodense as compared to the rest of the ear. And on delayed imaging, the scar will become hyperdense. The rest of the tumor will show washout, but the scar will become hyperdense. In initial arterial phase, the scar will be hypodense. The tumor will enhance. In the delayed phase, the tumor will wash out. The scar will remain hyperdense. And in the blood test, serum alpha fetoprotein levels are more often normal in fibrolamellar as compared to conventional HCC. What percentage of HCC will show raised AFP? Can you tell me a rough figure? 100%? Is it 100%?
No, sir. In cases of intrahepatic cholangiocarcinoma, FP is normal.
Our cholangiocarcinoma.
HCC.
We are talking about
60 to
70%.
Yes, 60
Very
to
good.
70%.
So, sir, is around 70% of HCCs you will expect to get a raised AFP, not 100%. So just because the AFP is normal does not exclude the diagnosis of HCC. Okay. So you have done the imaging, and suppose you don't get these features that you described, the early enhancement in the arterial phase. Can you tell me when is the arterial phase on the CT scan for the HCC? What is the arterial phase? How many minutes or seconds after injection of the contrast?
10 to 40
okay,
seconds.
So 10 to 25 seconds only there will be bright enhancement. Okay. So suppose this doesn't happen, or there is some amount of retainment of contrast. The contrast is not washing off in the portal phase or the delayed venous phase. So these are
it has lit up, but it is not washing. Yes.
Not washing. It's not a characteristic feature. Now, also alpha fetoprotein is say in the range of 40. It is 40. Upper value of normal is maybe say 5. It is 30 or 40. So it is raised, but it is not markedly raised. Can alpha fetoprotein be raised in other conditions?
Yes, sir. In hepatic.
Or is it only specific for HCC?
No, sir. In benign conditions like hepatocellular adenoma.
Malignancy. Also. Talk of malignancy first. Other malignancy where FP can increase. Think of some gonadal pathology.
Sir, gonadoblastoma.
Gonadoblastoma.
What happens in testicular malignancy?
Too many hints.
Oh yes, seminoma, sir. No, not in seminoma. Teratomas. Non-seminoma.
Yes. And other some benign conditions?
Sir, hepatocellular adenoma.
Adenomas, no. Hepatitis, conditions like hepatitis, you might have raised protein level. So it is not very specific, especially low values. If you have very high values, they are more or less HCC. Suppose in this case you don't get a raised AFP, classical of HCC. What next?
Sir, please may you repeat the question? I could not get it.
You have done the contrast CT, the triphasic CT, and the imaging characteristics are not classical of HCC. So it is not showing the typical early enhancement, early washout. Okay. And you have done a serum AFP. Serum AFP is mildly elevated, 30, 35.
Okay.
Is that enough for you, or do you want something else then?
Sir, then I may go for confirmatory, sir. I can go for tissue diagnosis.
Okay, fine. So in that case, that would be one indication of getting a tissue diagnosis. If your imaging characteristics are not classical and the serum AFP value is also not elevated. Okay, forget about it. So can you tell me what are the imaging characteristics of what are the common benign conditions of the liver? Focal benign lesions of the liver.
So benign like FNH, sir, nodule, focal nodular hyperplasia.
Commonest benign lesion of the liver.
Hepatocellular adenoma.
Commonest benign lesion of the liver, not adenoma, not FNH. Although I am not using the term tumor. Commonest benign lesion of the liver.
Sir, hemangioma.
Hemangioma, first. Second most common lesion?
Second, sir, then adenoma, sir.
No. Focal nodular hyperplasia. Some amount of theory also you have to know. Your presentation was good, but associated cross questioning you have to answer.
Yes,
Tell me the imaging characteristics of FNH on CT scan.
So FNH will be, sir, it will be there will be delayed washout, sir. Early uptake and delayed washout, and with a central scar.
Correct. There is also a central scar in FNH. Okay, and there is centripetal filling, gradual centripetal filling. So first of all, there is a peripheral nodular uptake, and then there is a central filling. Okay. So now coming back to HCC. So suppose you have done the CT scan and it has come out to be a classical HCC on imaging, and the alpha fetoprotein is also elevated for whatever level it might be. Does it have a prognostic value, alpha fetoprotein?
Yes, sir. It does, sir. All the tumor markers do have a prognostic value, sir.
How so?
What level? What level alpha
It
level
is-
suggests something is more adverse?
Sir, if it is more than, sir, if it is 5 to 7 folds more than the normal value,
Then what?
Then, sir, it's suggestive of poor prognosis, and sir, it is kept as a baseline before resectability, and it will also determine the functional liver remnant.
Functional liver element, alpha fetoprotein.
No.
Achha, do you have the CT pictures of this particular patient? Can you share them with us?
I'm sorry, sir. I'm afraid I don't have it.
You don't have a CT scan. Oh,
This might be a hypothetical case. Just keep on discussing.
Okay, fine. So I wish I had a CT scan. So how do you determine what are the anatomical segments of the liver, Dr. Ishita?
So anatomically, we divide by the quinoid segment, 8 segments. Segment in the right side, sir. In the right side, we have this segment 5, 6, 7, 8 means 5.
Very good. So after segment, what is the next higher level? These segments unite to form?
Sir, the lobe.
No, between lobe and segment there is another level.
Sector.
Correct. So what are the sectors in the right lobe?
Sir, sector is on the right side. It is right anterior, right posterior.
Very good. What are the segments in the right anterior?
Right anterior.
Yes.
Yes. 6 and 7.
No, absolutely wrong. 8 and 5. 8 and 5.
5 and 8.
6 and 7 are right posterior sector. Achha, what are the sectors in the left lobe?
Sir, left medial, left lateral.
Very good. Achha, how do you decide what is right lobe and what is left lobe on the CT scan?
Sir, on the CT scan, it is determined by the line, Cantley's line.
Very good. What is Cantley's plane, principal plane?
Sir, it is the line which is joining the IVC with the gallbladder fossa.
Right border of IVC or left border of IVC? IVC is quite a thick thing, you know. IVC is almost 2 centimeters.
IVC is a right structure, so it is left border of IVC.
Good. To the gallbladder fossa. That is the principal plane of Cantley. What important anatomical structure runs in the principal plane?
Sir, IVC.
IVC is one of the boundaries of the plane. How can it run into it? IVC is posterior to the liver. Some part of the liver goes behind IVC, but basically IVC is not part of the liver. It's called the posterior boundary. What liver structure?
As you split.
Sir, the middle hepatic vein, sir.
Say that. Okay. So middle hepatic vein runs in the principal caesura or the principal plane of Cantley, and that divides the liver into the right lobe and the left
Yes,
lobe.
sir. Yes, sir.
Correct. Okay. How about the right anterior and the right posterior segment? What divides them?
Sir, it is the right hepatic vein.
Correct. Where are these hepatic veins draining?
Sir, hepatic veins are draining in the IVC.
Okay. They drain independently
Sir,
and at the same level?
segment 1 has independent drainage.
What is segment 1? What is another name for segment 1?
Sir, quadrate lobe.
What did you say? Please repeat.
Quadrate lobe.
No,
No,
caudate.
caudate. Quadrate lobe is the difference. Sorry. Caudate.
Caudate lobe. Okay. So is that part of left lobe or right lobe?
Sir, it is a part of left lobe.
No, it
No.
is independent. It is not part of any lobes.
It,
Okay.
it has dual supply from both right and left branches.
Right.
Achha. So on the CT scan, now we know the basics of CT scan. We will be able to mark out which lobe it is present in. So what else now? So you have done the CT scan. It is a primary HCC based on the CT imaging. Now what?
Sir,
What are the important considerations to plan treatment? You got a diagnosis.
Yes.
Yes,
Now,
sir.
what are the
Sir, I will set a multidisciplinary team to discuss.
Before that, what you work up? What are the things you have to work up and tell the maternity team that these are the parameters? Now I think we take a decision. What are the things?
Sir, I will do some investigations for the preoperative fitness.
What you
preoperative? So you are considering operation.
Status? Is performance status important to plan treatment? Performance status of the patient?
Yes, sir. Yes, sir.
That is one. You have to assess the performance status. You have done that in general examination.
Yes, sir.
Second is liver function test important?
Yes, sir. Liver function test is important, sir.
So can you collate all of them and come up with some sort of a scoring system to decide whether the patient is fit for some kind of operative treatment or the patient needs something else?
Sir, yes, sir. The scoring system is the child-pook scoring system. The
one which is most commonly used is child-pook system. Can you elaborate what are the parameters used in the child-pook's CP score?
Now it is CTP.
Yes, child-pook.
She has mentioned that. Yeah.
Sir, it includes the serum albumin level, serum bilirubin level, the increase in prothrombin time in seconds, and ascites.
Can you tell me the values? What about your prothrombin time? What is A? What is B? What is C?
Yes, sir. Sir, prothrombin time, it is increased prothrombin time, the seconds. So it is in A, it is more than 4 seconds, and in B, it is.
How can it be more than 4 seconds? Less than 4 seconds. A is good prognosis, no? So increase is less.
Yes, sir. Sorry, sir. Less than 4 seconds, 4 to 6 seconds, and more than 6 seconds, sir.
Good. What else?
And ascites and hepatic encephalopathy.
Okay, good. So based on this, we divide them into A, B, and C. Can you tell me the total score? How much
sir,
total
15,
score?
15, sir.
Score that you can, minimum score that you can have?
Sir, 7.
No, why 7? If you get 1 in all 5, you mentioned 5 parameters. So what will be the minimum score?
So 5 to 7 we consider in.
So minimum score is 5. Maximum possible score is
15, sir.
15. What is child A?
Sir, child A will have a increase in prothrombin time of 4.
What is child A total score?
So 5
total score is.
Sir, child A is 5. 5, sir.
No, not just 5. What about 6?
So 5 to 7, I think.
No, not 7. 7 is B. 5 to 6
5
is child
to 6,
A.
7 to
7
13
to 9.
and 13 to 15.
No, not 7 to 13. 7 to 9 is B. And 10 to 15 is child C.
Sorry, sir.
Okay. So you would need to do a CP score. Okay. So suppose it is CPA. You have 2 patients. Same mass. One is CPA and one is CPB. Now what? What about the patient with CPA and what about the mass is the same size? Suppose let us give it an arbitrary size of 7 centimeters or 8 centimeters in the right lobe. Now what? Solitary mass.
Sir, then
One thing I forgot to mention, in the CT scan, are you looking for anything other than that? You've looked for the mass. Anything else that you're looking for in the CT scan?
sir, I will look for any metastasis, sir.
Correct. Where are the commonest sites of metastasis from liver cancer?
Sir, sir, gallbladder and sir,
Gallbladder is
lung.
not site for metastasis.
Liver cancer metastasizes to which organ?
Sir,
Most
lung,
commonly.
lung,
Yes.
sir.
Lungs. What else?
Sir, and sir, bones.
What
Bones.
else?
And
Adrenal is one important site for metastasis.
Okay, sir.
Okay.
and peritoneum. So lungs, bones, peritoneum, adrenal, you have to mention these. So you also have to look for this in. So you have to get a CT thorax also, not just CT abdomen. Okay. So you have done the CT thorax, you have done the CT abdomen. There are no metastases elsewhere. There is also no feature of chronic liver disease. So there is no ascites, there is no splenomegaly. You have done an upper GI endoscopy. There is no. What are you looking for?
So in upper GI endoscopy, we'll look for varices.
Good. Is a visual varices. There are no varices. Okay. So there is no portal hypertension. There is no cirrhosis. So HCC arising in a background of a non-cirrhotic liver in the right lobe. But one patient has a Child-Pugh A, one has a Child-Pugh B. Although I said non-cirrhotic, but assume that the second patient is slightly cirrhotic and has a CP score of B.
Okay.
CP class B. Now what? How will your treatment vary?
Sir, CTA means CPA. We will we can go for resection. And based
So
on
CPA alone is enough for resection. You don't have to think of any other consideration for a liver resection.
sir, we have to go for MEL scoring also. We have to also
MEL
check the
scoring is a score for liver for deciding on
MEL
transplant.
scoring is alternative to CTP. You either take CTP or take MEL score. But there are other parameters which you decide for planning treatment.
Yes, sir.
Surgery.
We have to check for the functional liver remnants, sir.
That is one.
Future
And what
liver
are the
remnants.
tumor size?
FLR. Yes. So how much FLR do you need?
Sir,
How much FLR do you need?
Sir, we need, sir, 30%. In a non-disease stage, we need 30% of.
What diseases are you talking about?
Cirrhosis, you mean?
Sir, the first patient did not have cirrhosis.
No.
Yeah, you said
30%.
non-disease. Is cirrhosis the only disease that you are worried about?
No, sir, hepatitis can also be cirrhosis.
What hepatitis due to? Hepatitis due to?
B and C.
Any other type of hepatitis you know of?
Sir, A, E, and D also.
No. I don't mean the different viruses. I am talking about hepatitis due to some other cause.
Okay, means steatotic hepatitis and
Steatohepatitis. That may be due to a variety of reasons. Maybe due to alcohol, maybe due to diabetes, maybe due to some chemotherapeutic that the patient has received before this. You don't always do a liver resection just for HSC. You may do liver resection for other liver lesions also, for which a patient may have received chemotherapy in them. So chemotherapy or chemotherapy associated hepatitis, CASH, right? So in that case, the FLR will have to be a normal.
So 40%, sir, in case of disease.
Yeah. For cirrhotic liver, the residual liver should be more than 40%.
Yes, sir.
Yeah. So how do you decide about resection versus transplant versus other therapies?
Sir, we check the Karnofsky score, sir, and
Okay.
sir.
Okay, let Dr. Ghosh ask. Yes. He got muted. Dr. Ghosh, can you hear us? Okay. Yeah. Oh, he'll come back. So what are the criteria to select resection versus transplant versus other local therapy?
So that is, sir, this University of California criteria and the Milan criteria, sir.
Yes.
So either one we can take, sir. If it is, sir, if the nodules are there, then means less than 3 nodules, and if it is a single nodule, then there
Can you
should.
tell me the ideal criteria for doing a resection? If you go by BCLC, Barcelona Clinic Liver Cancer Staging, they have 5 stages, stage 0 to stage D.
Yes, stage D.
Which stage is a good candidate for doing a resectional surgery?
Sir, stage A, sir.
Stage 0. Stage 0 and stage A, yes. Okay, because what is the problem with resection?
Sir, one is future liver remnant, and
more important is what?
sir,
There is high incidence of
sir, there is high incidence of metastasis and micrometastasis, sir.
not recurrence.
Okay, recurrence.
There is high incidence of recurrence, and these recurrences are usually multifocal recurrences.
Okay.
Okay. Dr. Ghosh is back. Yeah. Dr. Ghosh.
Hello.
Yeah, Dr. Ghosh.
Sir, I got disconnected. I'm sorry.
Yeah. I asked her, what is the indication? How do you decide about resection, transplant, and local ablative therapy?
Yeah. I heard that. And then I got disconnected.
Yeah. So she said that,
Yeah.
and I asked her, what is the problem of resection? The answer was, there is more chance of recurrence following local resectional surgery. And these are more of multifocal recurrences. Okay.
Yes, sir.
So, what are the different staging system in hepatocellular carcinoma to decide about the treatment?
So staging systems like Okuda staging system is there.
Let's talk of AJCC. That is a internationally accepted. Yes. But in liver tumor, they are saying that AJCC does not take into account the other important parameters. So AJCC is not a very favored classification for ACC.
Yeah, hardly ever used. Hardly ever. No major center of the liver surgery is bothered about DNM. Next is Okuda. Absolutely right.
Next is
sir, Barcelona liver.
And there is another called Italian cancer liver, Italian
CLIP.
CLIP. And the more accepted system is a BCLC, where they have taken into account performance status, the child score and the tumor size. So these are the 3 important parameters which are taken into account for planning treatment. Okay. So you said resection. Tell us the rationality of resectional surgery.
Means like how do we proceed? Like
what is the rationality? Why do you decide about the resection?
Sir,
why don't you keep all patients for transplant?
Okay. Sir, if means the liver can grow after resection. So
that is the point. You see, if you decide with the criteria, there will be huge list of patients waiting for transplant, and your supply is limited. You cannot plan for transplant in all patients.
Yes, sir.
Okay, but there are some specific indications where transplant is
where male score is less than 13, sir. So we go for and other.
Sir is asking for broad principles. Broad principles. Don't have to go for specifics. As a postgraduate, general surgery postgraduate, you need not go into great detail, and you will not be able to remember so many things. You have to remember hernia also. You have to remember varicose vein also. So
one we have discussed is
the point is
a small tumor.
The whole.
It's a small tumor, preserved liver function, good performance status. That is an ideal candidate for resectional surgery.
Resection. Okay. Whereas if the liver is totally diseased and there is a background cirrhosis, in that case, you will be more towards transplant. That is all. You say that broad principle.
Yeah.
And what about if the patient refuses surgery? Now what? Sir, the surgery is a major surgery, isn't it? It is associated with morbidity and mortality. You have to mention mortality. So in our hands, the mortality is 10%. We should not be saying it in public, but it is at least 10% or even more maybe. But if the patient hears that, patient will be scared and say, no, I don't want surgery. Give me some other option. What are the other options?
If the patient can afford, sir, we can offer the patient radio frequency ablation and
radio frequency ablation. What are the principles?
Sir, principle of radio frequency ablation is we so we expose the tumor, means we expose the tumor to
Surgically.
No, sir, it is not surgical. It is radio, means with the help of
This can be two ways, either image guided, and now
image
people are
guided. I
doing,
mean to
or
say that
laparoscopy guided. Okay, it can be image guided or laparoscopy guided. And the
So what
principle
will
is
you
what?
do?
Principle is what? What damages the cells?
sir, it is high energy is given to the cells, sir.
Thermal.
How do you give the
How
energy?
is transmitted to the cells.
How is it? What energy?
Sir, thermal energy.
Some
Sir.
energy, you know? Huh?
The
It's
thermal
a radio
energy.
frequency wave.
How?
It's
Then
a
why
radio
not
frequency
call
wave.
it heat probe? Why not call it a heat probe? Why are you calling RFA?
Sir, because we don't need a direct contact. Heat probe, we need
Huh?
a
You don't need a contact.
You
The
need a
probe is not in the tumor.
He's in the contact.
uh,
You are delivering radio frequency wave, which is converted to
sir,
You
heat.
attach you put in a probe. See, you put in a probe. The probe is placed in the center of the tumor. Normally, if it's a small tumor, assuming that it's a small tumor, you put in a probe. That probe, as sir said, it can be put percutaneously under image guidance, or you can do it in surgery, during surgery. And then you attach an alternating current, high frequency alternating current to that probe. That makes the tip of the probe vibrate very fast. And that vibration causes heat energy to be produced at the tip of the probe. And that heat causes
coagulation necrosis, sir, of the neck tumor.
Right, because of heat. So up to 60 degrees centigrade, it goes up. But what are the limitations? What are the limitations?
Means important structures cannot be nearby, and sir, 3 centimeters.
That is okay. But what are the other technological limitations? If it is so good and it raises, if the cells receive 60 degrees centigrade, the cell will die. Then why not do radio frequency ablation for all? I am telling you, the HCC cell will die if the cell is given 60 degrees centigrade. Then why not do RFA for all patients?
Sir, but it destroys other surrounding circumferential tissues as well.
Let it. Also, even surgery destroys the normal tissues. You can't just enucleate a HCC. You do a right lobectomy, a right hepatectomy, I mean. So that takes away a lot of normal cells. Lots. See, the technological situation is such that the zone of coagulative necrosis that can be produced is maximum of 5 centimeters right now. We don't have probes which can produce more than 5 centimeter zone of necrosis. So if you have a larger tumor, then you cannot do it with one probe. Then you have to plan and put the probe, more than one probe. And so place them in such a manner that the zones of coagulative necrosis overlap and cover the entire tumor. So the larger the tumor, the more technically difficult it becomes. Try to imagine in 3 dimensions, you have to make different spheres. The zones are spherical. So you have to place different spheres which totally ablate a structure which is not necessarily a regular structure. And liver cancer may not always be absolutely geometrical. Huh? It may be an infiltrative lesion. So for larger lesions, technically it is very difficult. For a very small 3 centimeter lesion, you have to have 1 centimeter margin. So for a 3 centimeter lesion, you need to have 1 centimeter on this side, 1 centimeter on that side. So 5 centimeters in all. So the larger the tumor grows, the more difficult it is to achieve control with RFA or cryoprobe. Okay. So for small tumors, it is very good. It is almost as good as resection surgery, probably better if a patient has got lots of comorbidities.
There are some comparisons saying that RFA is acceptable as good as resection.
Larger the tumor grows, RFA will not be able to control it. It becomes very difficult to plan. Place the probes in different ways to overlap the zones and the uniform destruction of the tumor cells. Same with cryo. Then cryo has a specific disadvantage. There is something known as a heat sink effect.
Heat sink effect, sir. Yes, sir. Sir, sir, the energy we give to the tumor, that actually means the molecule. No, that's a micro.
Gets lost if it's near a major vessel.
Yes,
the cell takes away the heat. Yeah. So then it is not so effective in the tumor cells which are near that vessel. Those tumors don't get heated up to the specific temperature because the constantly flowing blood carries away the heat large extent, right? So these are some of the limitations of ablative non-resectional therapies. Any other option you have for a very small tumor?
Sir,
We have mentioned RFA, we have mentioned cryo.
The transarterial chemoembolization, sir. So through hepatic artery.
Ablative. Yes, that is also an option. Something more simple.
So microwave therapy, sir.
Microwave, yes, that is also an option. What about,
Any
haven't you heard of
percutaneous
percutaneous
injection?
ethanol injection?
Sir,
Percutaneous
ethanol injection, sir.
Say simple things first. That is something which you can do in Bagu. Microwave, I don't know whether you have in your hospital, but you can get ethanol, absolute alcohol. And if you have a intervention radiologist who is reasonably skilled, you can do it in your center if you get a small tumor. Then there are very lot of high technology things like IRE, irreversible electroporation. You have heard of that?
Yes, sir.
So, but that is not easily available. I don't know whether it is available at all in any center in West Bengal. So let us talk about things which we can do in our state, in our city.
RFA available in Thakurpukur. RFA they do. Thakurpukur they do RFA ablation.
RFA is there in many places. RFA is there in private sector also, in many centers.
Suppose you are concerned for liver transplantation. What are the criteria to consider patient for liver transplant in ACC? Because beyond that, people doesn't consider for transplant.
Sir, if the serum bilirubin is less than 2.
No, what is Milan's criteria? And UCSF criteria?
Sir, Milan's criteria is if there is a single tumor less than 3 centimeter in size.
No, not 3. Single tumor is 5 centimeter.
5. Single centimeter is 5 centimeter in size, and if it is
cumulative is 7.
Multiple, then it should be less than 3, and cumulative diameter should be less than 7.
7, correct.
3 tumors equal to less than 3 tumors, none more than 3 centimeter. And it has been stressed up with some other criteria. Some people are saying that you can stitch up. What is that?
University of California criteria.
What is that?
Sir, single tumor diameter should be less than 6.5 centimeter, and cumulative diameter of the tumor should be less than 8 centimeter, and
multiple tumor less than 4.5 centimeter.
4.5 centimeter each.
Yeah. So what is the advantage of liver transplant in ACC management? Why people are going more towards liver transplant even in early disease?
Sir, we get rid of the disease liver.
Right. Yeah. So briefly that you have said. So liver HCC occurring in a background of
micrometastasis, there is no recurrence chances, and there will be no residual micrometastasis.
And you treat
distant micrometastasis will be there. You see, if there is distant micrometastasis, that cannot be taken care of by liver transplant. Okay, you can take the liver problem. That means other recurrence as you find in local resection, that will not be there. And if the patient got cirrhosis, on the background of that,
disease burden and tumor burden will also reduce.
Yeah. Okay, so we hardly ever do transplants. Liver transplants are very infrequently done in our city, but liver resections are fairly routinely done. Can you tell me what are the methods of dividing the liver parenchyma during liver resection? Because it bleeds a lot. If you just try to cut it like you cut the stomach or you cut the pancreas, it bleeds a lot. So what are the different energy devices used?
Sir, the ligashore can be used, sir.
What is ligashore? What is the principle of ligashore? What's the principle of ligashore or ligashore?
Sir, it is harmonic scalpel.
No, ligashore.
Ligashore and harmonic are two entirely different things, madam.
Sir,
ligashore is what?
It is coagulates.
Bipolar. It's a bipolar diathermy.
Okay, it's a bipolar diathermy.
What about harmonic? Now you have mentioned harmonic. You must mention harmonic.
Sir, ultrasound waves helps in coagulation.
Have you heard of CUSA?
Yes, sir.
What is CUSA?
What CUSA stand for?
Sir,
what does the CUSA stand for? Cavitronic?
Ablative ultrasonic.
Ultrasonic
surgical aspirator. So harmonic is ultrasound, CUSA is ultrasound. Are they the same thing?
And sir, crushing.
What happens in CUSA? Have you seen people using CUSA?
Sir, heard.
In CUSA, you can ablate the parenchymal tissue.
No, you said harmonic is ultrasound, isn't it? Yeah. Harmonic is ultrasound, CUSA is also ultrasound. So are they the same thing?
No, sir. In harmonic we cannot cut. But in
you can cut in harmonic. Why not?
You can take the scissors and cut. Why do you need to cut? The harmonic is ultrasound. Didn't you say harmonic is ultrasound?
Yes, sir. But it
And
coagulates
QSA is
it,
also
and-
ultrasound.
but we have to take a different instrument. In harmonic, sir, we
So
cannot.
why, if it is ultrasound, if both are ultrasound, why are they two different instruments?
Sir,
What is the difference between harmonic and QSA?
Sir, it means it coagulates and cuts as it.
Which?
Sir,
Which
kusa.
cuts?
Sir,
No
kusa.
cuts what? It cuts the vessel. So you are going through the liver parenchyma and you have encountered the middle hepatic vein and you are using the QSA on it, it will cut the middle hepatic vein. Whereas harmonic will not cut the middle hepatic vein. Is that what you are saying?
So it will first coagulate.
Which
Means,
will first coagulate?
Sir,
The QSA will coagulate the middle hepatic vein and then cut it. So so I can give you the QSA and you will just resect the liver. Then. No problem then.
I'm sorry.
It will
sir,
coagulate and it will cut. What more do you need? You don't need anything else then. So then tomorrow I can place a QSA machine at your disposal and you will do all the liver surgeries, provided the FLR is okay. It is not so simple. You have to read. Huh? So I will not tell you this. You are a postgraduate. You will not be spoon-fed. Read the difference between the coagulation or the liver resection of a harmonic scalpel, which is also ultrasound, and a QSA, which is also ultrasonic energy. Okay.
So I conclude by asking, what is the treatment for advanced disease? Suppose you have a intermediate advanced disease, stage C Barcelona. What should be the treatment option?
So, stage C, sir, we can go keep the patient for transplant, and or else we can.
Stage C, not for transplant. No.
Sir,
Barcelona.
Barcelona stage C. No.
Stage C.
Stage C advanced disease.
Sir, we will CP. Sir is saying CPC.
Sir, sorafenib, we will give chemotherapy agents like sorafenib, sir.
That means the idea is palliative.
Palliative, yes, sir.
Ideally palliative. Okay. So there are some palliative options for one option is just a supportive care. And sorafenib has shown some improvement, but its long-term improvement is not there. Okay, but it provides good palliation. And there are some role for giving intraarterial chemotherapy.
Yes, sir.
Okay, but survival is not very
same as transarterial chemotherapy. Means that is the same thing. And transarterial radiotherapy is also there.
Yes, TAR is there. Transarterial radioembolization using yttrium microspheres. Yttrium microspheres. It is very expensive. But anyway, you can do it. Theoretically, you should definitely discuss it. Yeah. Okay, sir, I think we are running out of time now.
Yes.
Thank you, sir.
Thank you. Dr. Maiti, any comment or any question? Dr. Maiti? Sure, yes, thank you. We have to go to hospital, I understand. Yeah.
Thank you, sir.
Just 2 minutes.
Dr. Saha, Dr. Saurabh,
yeah.
It is a very difficult subject, even for the teachers. But you have discussed it very nicely after a long time. I am very happy to see Dr. Ghosh, Professor Ghosh on the screen. Thank you. And thank you, Ishita. You have answered very nicely.
It's very good. You have presented very well. Bashak, Dr. Bashak.
Good morning.
Yes.
Good morning. Nice presentation, Saurabh, and you have covered all the points nicely. One small thing is that when we are using the radio frequency ablation, we cannot do ablation very close to the portal vein or hepatic vein because the temperature is flown away, so the result is incomplete and it may cause damage to the veins. That point what I remember, but everything is covered 100% coverage. Thank you.
Thank you.
Excuse me, sir.
Thank you, sir.
I'll go home and come. Yeah. Yes.
Early washout and late washout. Why these happen, sir?
You see, washout is what? When the tumor is vascular. Suppose is a hepatocellular carcinoma. The vascular is because of arterial supply, not by the portal venous supply. So once you inject, the contrast first goes to the arterial supply. So you get the enhancement in the arterial phase. And if it is a hepatocellular carcinoma, in this next phase, this get washed out. If it is a hemangioma, the washout is delayed. The contrast is retained in the hemangiomatous tissue. So that is the difference. If it is the arterial supply, this arterial supply comes early enhancement and then early washout. Okay, same. Thank you.
Okay.
Thank you. Thank you. Bye. Bye.